Hi, Ms. Dabney. Stephanie Adamczyk here, presenting my Clinic 5 case-based patient, and I chose case study number 12. Moving on to slide number 2 is my patient profile and medical history. And so I had a 71-year-old white female. Her medical history is significant for previous breast cancer that did lead to a mastectomy 6 years ago. She did receive 6 months of chemotherapy as well as 9 weeks of radiations with no complications. The patient isn't taking any prescription medication at this time. However, she does take 1 baby aspirin daily to help with her blood thinning. She does have a history of stomach ulcers and hernias, and that medication was prescribed for in the past. However, she's not taking anything currently, and she hasn't had any GI difficulties in the last 12 months either. She does report that she has some occlusional arthritis that she suffers from, and she does take a pain reliever. However, she can't recall the name of it, but she knows it's not ibuprofen. She also informed me that she smokes a pack of cigarettes a day, and she has for the last 50 years. Moving on to slide 3, medical history continued. The patient's dental history is significant in the fact that she hasn't seen a dentist in the past 10 years. However, she does listen and follow dental hygiene recommendations, and having her recare done every 6 months. The patient's chief complaint is regarding her stain on her teeth. She also has a few questions regarding the gold bridge that she has. She's noticed that it started to wear, and she's wondering if that needs to be replaced sooner rather than later. Moving on to slide number 4, EO-IO examination. Extraorally, the patient's facial symmetry, lips, TMJ, larynx were all within normal limits. However, the patient's submandibular and posterior cervical lymph nodes were palpable. Moving on, intraorally, the overall appearance of her gingiva appeared generally blunted interproximally, with minimal bleeding upon probing, stippled, and it appeared to be firm. The hard palate appeared vaulted with flat rugae and a flat incisive papilla, as well as a torus palentinus. There also appeared to be supragingival plaque at the gingival margin on 1/3 of all the tooth. Moving on to slide number 5, this shows this patient's perio chart. So it shows which teeth are clinically missing, her furcations, her mobility, her recession, her pocket depth, and so on and so forth. Moving on to slide number 6 is her plaque-free score. So this is the diagram that I use to help manipulate her plaque-free score to what we usually do in clinic. This is what I used. I canceled out the clinically missing teeth, and then the red is the teeth that have any sort of plaque or biofilm on them. Moving on to slide number 7 is my patient's OHI. So I made a chart of the questions that we ask, their responses, and then our recommendations depending on the response we get from the patient from the question that was asked. So moving to slide number 8 is her risk assessment. So this patient is at risk for all of the following categories: caries, periodontal disease, oral cancer, nutritional concerns, need for fluoride, and need for a referral to a general dentist. So she is at risk for all of those, the reasons why, and then the recommendations for her as well. Moving on to slide number 9 is her hard tissue chart. Clinically missing, PFMs with endo, clinically sound, and then in red are what needs to be watched or what needs to be fixed. Moving to slide number 10, shows her full mouth series I had gotten. Moving on to slide number 11 is intraoral images. So it really has a show for what her teeth looked like. She has a lot of PFMs in her mouth. Moving on to slide number 12 are more intraoral images. You can see a photo of that gold bridge that is one of the patient's chief complaints, as well as the recession that she has and the stain on the lower anteriors. Moving on to slide number 13 is my patient's treatment plan. With all the information that I have gathered through this initial appointment, I categorized her as an AAP case type 4 mod SCRP with a 3-month recare. So between slides 14 and 15, I have my progress notes written. I have 3 entries for the 3 times that she came in, all the information about what was done, what local anesthesia was given, how the patient reacted, and so on and so forth are all in between slides 14 and 15 for the progress notes. Moving on to slide 16, post-treatment findings. During the multiple appointments that were needed for this patient, I noticed on the last appointment that she had multiple intraoral blisters that didn't seem to bother her. Her chief complaint was regarding the stain on her teeth due to the fact I suspect that she has smoked a pack of cigarettes a day for the past 50 years. She was satisfied with the final appearance of her teeth and at the end of the 3rd appointment. Overall, the hard tissue exam went well and both the patient and Dr. Holwig were satisfied. By the end of the 1st appointment, her flossing technique appeared to be improved. I recommended an electronic toothbrush as well as Listerine Total Care that will help with future decay problems that she may have. If the patient continues brushing and flossing daily and hopefully quit smoking cigarettes when she's ready and stays on track with her new recare appointments of 3 months, I believe the BOP will reside and the pocket depths will shrink up and become healthier than they ever have. Moving on to slide number 17, which is my summary. So, a 71-year-old female who is a cancer survivor presented herself to our clinic on 1/16/2020. Her chief complaint was the stain on her teeth and her gold bridge. She informed me that she smokes a pack of cigarettes a day and has for the past 50 years. She hasn't seen a dentist in 10 years but follows recare recommendations every 6 months. On the initial appointment during her oral exam, her submandibular and posterior cervical glands were palpable, and she was referred to her general physician for further treatment. When Dr. Holwig came to do her hard tissue chart, the patient asked a few questions regarding her gold bridge. Dr. Holwig proceeded with the exam and informed the patient that the bridge was fine. However, it is starting to wear since it is 10 years old. He said it was fine for now, but we will keep an eye on it these next few years. Other than that, it looked like there's a short crown prep on number 12. It took 2 more additional appointments for her treatment to be 100% completed. On the 2nd appointment, she requested all surfaces of her teeth be polished with a rubber cup polisher, which was done after local anesthesia was given on the upper and lower right side of her mouth. Once she was numb, I began scaling and replaying the lower right. Once that was completed, I moved up to the maxilla. There was a good amount of bleeding, but overall the patient was comfortable as I continued to work. At the end of the appointment, I informed her that her gums may be a little sore, and if they are, she can take whatever she normally takes for any pain relief that she may have. Moving to slide 18, summary continued. At the 3rd appointment, the same thing that was done at the 2nd appointment was done here, but on the opposite side of the mouth. We reviewed her medical history and OHI, then local anesthesia was given to the upper and lower left side of her mouth. I began scaling and replaning the lower left, and again, once that was completed, I moved to the maxilla. Since she was considered a 4 mod, she had more supragingival calculus and plaque. However, I struggled with the subgingival calculus the most. I believe that the pieces that were there had been there far much longer than only 6 months. There's a little bit more blading on the left side of the mouth than the right, but I think with the OHI instructions that was given to her, that the gingiva will tighten up and be healthier than ever. Overall, the 71-year-old patient did better than I anticipated. I think if it would have taken me 5 times, she would have came in smiling every single time. Moving on to slide 19, learning experiences. I believe having this patient as my case-based patient really made me look more closely. I think a lot of the time we as students in clinic know we are on such a time crunch that we go quickly through a lot of the steps that should probably be looked at with a little more detail. Since I knew my patient would be able to come in as many times as I needed her to, I felt I took my time in retrieving the intraoral images that were shown in this presentation, as well as a very thorough perio chart and EO-IO exam. It also helps when you know you have a patient that you can count on to show up. Being a student in a clinical setting where we are dependent on patients makes it hard to keep a positive mindset. We've all had patients no call, no show when we really needed them to be in our chair. Learning to have patience, compassion, and honesty with our patients will make us far better clinicians than we all could have ever imagined. We are in a career that helps people, and in order to help people, we need to be able to do the best we can with what we have and the time we have. Having confidence in our patients that they will show up on time is something we all need to be a little better at as well. Then moving on to slide 20. That's my conclusion for my case-based patient. Happy Easter, Miss Dabney. Hope you and your family are safe and doing well. And we hope to be back in clinic and finish what we started. Thanks again, and have a good rest of your day.